at 1:30, as far as I'm aware, Cliff Davis is going to join us and do some dosage calc. And what I thought I would do is just see your presentations and just talk about hypertension a little bit, risk factors, pieces that you saw as educationally important, and give you a 10-minute break before he comes in and talks about dosage calc. And sometimes, I don't know if you had the opportunity to look at the dosage calc slides that Miss White gave me that I uploaded last week for you. It sort of really outlines how she, works her dosage calc. So for those of you that are having issues with dosage calc, which is really all of you, I would strongly recommend that you look at those slides that I posted. There's 2 attachments, and that might be helpful for you. Okay, so I'm always excited to see what people do with in their teams. So Evelyn and Elisa, are you the team leaders? Is that what's going on here today? Lisa's laughing.
Me, that's up to you. How do you want to do it?
I don't care, love. We work together, so it don't matter.
Yeah, it doesn't matter. We can do it. How do you want to do it?
Yeah, we bomb like that. Either one of us can handle it.
All right, that's lovely. One of you take the lead.
I'll show the screen, Ev. You just do it, okay?
Okay.
Oh, goodness. Right. So I take it you 2 are going first then.
Oh, it's no worries. We got it. Just let me pull up everything.
Yeah, we're going first.
Okay.
Hold
on. We went with a brochure this time.
I'm so impressed.
And you'll want to take it with you to work.
Excellent. I love that.
So we're gonna do, we're showing the PowerPoint and the question and the
Well, let's do this. I mean, the thing is, I think, let me just look at the whole thing with the hypertensive crisis first of all. First of all, let's do this. Let me look at both of your presentations and see what you did from an educational perspective. And then as a group, we can talk about the questions regarding this particular patient and the hypertension, the hypertension and what the questions were about. So let's see your brochure first of all as to
the brochure. Okay.
Yes, the brochure and how you would educate this patient. What would you do?
Let me pull it up. Let's see. Yeah, share my screen. Really? All right, Ev, can you see it?
I can.
All right. It doesn't pull up like a PowerPoint, so this is about the goodnesses we're going to get.
I can't see it yet.
You can't? It should be showing. Oh, here. There you go. Is it? Yep, there you go.
Okay. There.
Yay! Beautiful.
Okay.
Hey, so, I'm sorry to burst your bubble, but there's a hypertension. Sorry.
I spelled it wrong?
I mean, just saying.
Evelyn, why you didn't tell me?
I'm sorry. I usually get the corrections on the spelling. I screwed up.
It's okay.
Just HYPER.
Just maybe I'm not going to post this yet.
Don't do that. How you spell it?
SION.
That's okay.
Oh my God.
It's okay. This is why we have proofreaders, right?
I was supposed to be the proofreader. I sucked at it today. All right, you ready?
I am.
Yeah. Okay. So on the front of the brochure, it says, what is it and why me? And it tells about high blood pressure is a common condition in which the long-term force of the blood against your artery walls is high enough that it may eventually cause health problems such as heart disease. Blood pressure is determined both by the amount of blood your heart pumps and the amount of resistance to blood flow in your arteries. The more blood your heart pumps and the narrower your arteries, the higher your blood pressure. You can have high blood pressure, hypertension for years without any symptoms. Even without symptoms, damage to blood vessels and your heart continues and can be detected. Uncontrolled high blood pressure increases your risk of serious health problems, including a heart attack and a stroke. High blood pressure generally develops over many years and it affects nearly everyone eventually. Fortunately, high blood pressure can be easily detected, and once you know you have high blood pressure, you can work with your doctor to control it. Okay.
And I love the balloons. That's clever.
Then it goes to symptoms. Most people with high blood pressure have no symptoms, no signs or symptoms, and even if the blood pressure readings reach dangerously high levels. A few people with high blood pressure may have headaches, shortness of breath, or nosebleeds, but these signs and symptoms aren't specific and usually don't occur until high blood pressure has reached a severe life-threatening stage. A normal range is 120 over 80 or a little bit below. Pre-hypertension is 120 to 139 over 80 to 89. And hypertension is over 140 over 90. We put on there. And then your risk factors are age, race, family history, being overweight or obese, not being physically active, using tobacco, too much salt or sodium in your diet, too little potassium in your diet, drinking too much alcohol, stress, and certain chronic conditions. Non-pharmacological things you can do is exercise, proper diet, sleep health, relax, no smoking, and decrease drinking. And then we also added that DASH diet, some basics on the DASH diet.
Wait.
I love it.
Do the sometime pregnancy thing.
Oh, I'm sorry. Sometimes I can't see it. Sometimes pregnancy, I can read it now, contributes to high blood pressure as well. Although high blood pressure is most common in adults, children may be at risk too. For some children, high blood pressure is caused by problems with the kidneys or the heart. But for a growing number of kids, poor lifestyle habits such as unhealthy diet, obesity, and lack of exercises contribute to high blood pressure.
I'm so glad you brought these points out. This is wonderful. I love what you've done. And I really like things like this because, you know, you can fold this up, give it to the patient, circle things that are relevant to them, right? And have it as a teaching tool. That's the whole point. The group team 2 or team, whichever team is team 1 and team 2, what do you guys think? Any thoughts?
It was great meeting you.
Kaylin, Rhonda?
Alicia, what you can do it.
Well, you know, there's a couple of things I want to bring out in that. Can you pop it back up again? Is it, or have you? A couple of things I want to pull out of there that I think are relevant.
Where about?
Okay. So the risk factors, for instance, I just want to go down to that. So within these risk factors, of course, we have some that are non-modifiable, right? Certain risk factors are non-modifiable, age, race, those types of things. I can't change my family history, but there's a lot of them there that are what are called modifiable, which we can change. And there's a lot that we can do regarding that. Obviously, a pregnancy state, we can't change that either. The other thing I really want to bring out is this piece that was in the small section, but is a very important section that that the CDC has noted for years has become such an issue that they even put it on the Healthy People 2020 guidelines. They put it on the guidelines prior to that as well, which is this issue of childhood obesity. And the types of foods, the lifestyle, of course, they're doing gaming more than getting outside and exercising, all sorts of foods that they're eating or not eating the correct foods. So we are seeing children that are truly morbidly obese, which is probably unthinkable even 20, 30 years ago, right? So this little piece here is not just for that patient, it's also something that we can teach so that the patient can be a role model for their children. Yeah, that's how I look at this as well.
Right.
You know, because kids are, you know, they're sponges. They soak up what they see. So if what they're seeing is mum and dad not really living or even trying to live a healthy life, then it's very difficult for the child to say, hey, I'm going to go it alone and really try and be healthy. True. So these types of little brochures and things are very, very helpful. The other thing I want to bring out as well is, what do we mean by sleep health? Anybody
Sleep
know?
health is because people don't take their sleep seriously enough, right? They feel like some people say, "Oh, I work nights, so I can't go. When I fall asleep, you know, it's whatever, and I'm right back up because I had something to do during the day." So they don't have the opportunity to just sit there and allow their brains to rest and to recuperate and regenerate themselves. So getting, you know, people, it's not, oh, I need 8, 9 hours of sleep. It is recommended that you get 7 to 9 hours of sleep or whatever, but anything less than, like, you know, 6 hours of sleep, you're in the danger zone, and then that's causing bad health. And because you're going to have bad eating habits. The longer you're up, the more you're going to want to snack and eat. The less you're going to be busy with something else. You're going to be shopping. You're going to be doing something. You're not going to go and exercise and do what you need to do to regenerate your mind. So you're just like with any health condition, your mind needs to be refreshed and rejuvenated in order for you to be able to fight off infection, and in order for you to be able to be at your healthiest and want to be motivated to get enough rest to get up and exercise. So your sleep health is very important and should be taken in consideration in not just hypertension, but in every type of health condition, period. Heart health, you know, sleep apnea, all of that, stress factors, all of that. Your sleep health is imperative.
Well, I'm really glad that you brought that out. You know, there was a study done with nurses that do night shifts, and unfortunately, the incidence of breast cancer is higher with nurses who do night shifts. And I don't have the citation of the actual study with me, and a lot of that is also a risk factor. You know, there's more inflammatory processes taking place when you're not getting the sleep that you need, and the restorative factors that you need regarding your sleep. So I'm really glad you brought that out. Good job, guys. Did you enjoy doing that?
Of course,
Yes.
I enjoy everything with Ev. And Kaylin, of course. You know.
All right. Well, I have a feeling that you're going to get wowed by the next team. So let's see what they've got going on.
Sure did.
Who's going to be your spokesperson?
Alicia.
I'm gonna pull I'll pull it up so you guys can see it. I'm gonna read it though. All right, let me see if I can.
I know you did that hit a
Can team
PowerPoint.
one please submit theirs so I can grade it?
Yes, ma'am.
I ain't do a PowerPoint this time on it. Do a PowerPoint this time. Let's see if I can get it to pull up properly. All right, you guys see it? It's not even hard to see.
So what did you do here? You did a document, right?
It is in a way. Let's see if I can get it to.
So remember, I said I don't need the actual. I think you want to give me the other thing, right? What? I want your educational piece of what you did.
All right. I don't think I think it's not gonna fit the view I needed to do. Alright, that's part of it. It's not showing properly. It's not showing. Oh wow, it just did its own little thing on the page here. It moved.
Oh, what the block here?
Yeah, the whole
This?
image just changed itself completely when I had it up.
Yeah, that can happen.
Alright.
Take your time. Got plenty of time. So what did you guys, oh, I see, you looked at stroke as an issue, right?
Mm-hmm.
Okay. So that's where you went with, okay. The potential for that. Okay.
Spelling error.
Yeah.
Yes.
I told you
All
it
having
changed
trouble
itself
today.
completely because it did not look like that a minute ago. Because I had it spelled right.
Uh-huh.
I did. I'm like, wait a minute, why are my words
You
different?
know
Just
what?
like
Let me
color
look at
changes.
what you, I can look at what you submitted.
Yeah. Wow, it did its own thing. Okay,
I
so
submitted it.
Wait, you know what? You did it as maybe a PDF and then converted it to a Word doc. And sometimes when you convert them, they can be a bit quirky. So
yeah,
I
go
think
wherever
that's
they
what
change it.
happened there.
Yeah. So
Let me
I
see
put
what you did.
the risk factors, I'm tongue tied already, are hypertension, smoking, diet, stress, hereditary disorders, cardiovascular disease, age, and race.
Okay.
We come down.
So who are you educating here?
Oh wow, it's really choppy because it's missing 3/4 of what I need. Hold on.
If Miss Fletcher can pull up the PDF that I sent her, we could see it much better.
Okay, you do that, Rhonda.
Oh, I can't do it. I'm on my phone.
Ah.
Hold on. Let's see if this does it better.
Oh, you're going to send her the PDF? Is that what you're saying?
Let me see
Now maybe it'll view it better. It'll show everything better.
if I can put it up better.
Sorry, this was very hard to say. Alright, so let's see. So I don't know if you guys can see it, but the non-pharmacological management measures that I put in there were the surgical clipping.
Well, tell me, go from the top here, because what are you, first of all, go from the top, because I want to understand what your focus is.
I know. All right. I put what the risk factors were: hypertension, smoking, diet, stress, hereditary disorders, cardiovascular disease, your age and your race.
Okay.
And I put a little information on what her problem was. So I don't know. I think I mashed too many things together to make it work.
So what you're trying to say is because of these risk factors, she's at risk for a hemorrhagic stroke. Is that what you're saying?
Yes.
Okay. Okay. All right.
Come down. And then what I put is the non-pharmacological management measures would be the types of mainly surgeries, which aren't like actual pharmacological medications that they would use, like a surgical clipping, where the surgeon places a tiny clamp at the base of the aneurysm to stop the blood flow to it. The clamp can keep the aneurysm from bursting, or it can keep an aneurysm that has recently hemorrhaged from bleeding again.
Okay.
They also have a coiling, an endovascular embolization, where they use a catheter inserted into the aorta in your groin and guide it to your brain. Your surgeon will place a tiny detachable coil into the aneurysm to fit it. This blocks blood flow into the aneurysm and causes the blood to clot. And there's a surgical AVM removal, where the surgeon may remove the smaller AVM if it's located in an accessible area of your brain. This is an estimated risk for rupture and eliminates the risk of rupture and lowers the risk of a hemorrhagic stroke. However, it is not always possible to remove the AMV if it's located deep within the brain. It's large, or its removal would cause too much of an impact on brain function. The systemic radiology.
Just stop a minute. What is an AVM?
I know what it is. I can think of what the word is. I just can't think of what it means.
It's an arteriovenous malformation. Okay.
Mm-hmm.
And usually that's more of something that happens at birth, by the way, more than something that's it's more of something that's noted more at birth, just FYI.
Mm-hmm. And then there's a stereostatic radiosurgery, where they use multiple beams of highly forced radiation. Stereostatic radiosurgery is an advanced, minimally invasive treatment used to repair blood vessel malformation. And you can use proper diet and exercise. And then there are the treatment teams that you would need, which is a neurologist, a rehabilitation nurse, a dietitian, physical therapist, occupational therapist, recreational therapist, speech pathologist, a social worker or case manager, a psychologist or a psychiatrist, and a chaplain.
Okay. Question, what made you decide that you didn't want to add medications in on this?
Not all medicines work sometimes for some people.
Okay. All right. On these types of hemorrhagic strokes, is that what you're saying?
Mm-hmm.
Okay.
And put the picture of an example of two different types of strokes that there are, which is a hemorrhagic, which is the second one, where it shows how the blood vessels ruptured.
So what do you think that therapy would be doing with these patients?
If they didn't improve from the results of the strokes, it would show them how to be able to make changes necessary, like how to eat, how to exercise their limbs, how to improve their speech, things like that.
Mm-hmm. Okay. Do you think maybe these patients eventually are going to need they may, I would think they're going to need some form of medication, to manage their hypertension, right?
Mm-hmm.
To prevent that from bursting, so that the vessels there's not going to be this extra force on the vessels. So they're probably going to need some element of antihypertensive medications to help with all of that, to prevent.
They're going to need an aspirin.
Yeah, I would think so. At the very least.
Yeah, at the very least.
Mm-hmm. Yeah. Those types of medications. They may end up with things like labetalol, your beta blockers, those types of things. Maybe diuretics to decrease pressure. So there's a lot of different meds. I don't know if they would have a clot buster first, to help with that, because if there's the risk of hemorrhaging, then they may not. But there are certainly a lot of things that you're going to look at from the medication perspective as well. Let's see. The only problem is with aspirin, you've got that double-edged sword. That, of course, what does aspirin do?
You blood thinner.
It's a blood thinner, right? So, yeah, you know, again, it just depends on the guidelines of the neurosurgeon and the neurologist as to what the latest guidelines are, depending on what they want to do, whether there is something that if they're going to use aspirin or not. That is a potential.
At least an 81 milligram.
81 milligrams.
Yeah.
Yep, absolutely. So there's a lot of different things that you would do pharmacologically for these types of patients. So what I want to do is just go over this particular hypertensive crisis with this particular patient. So she's a 43-year-old African-American female. So she's young, right? That's young, quite frankly. 43. And she's having the worst headache of her life. Now, when people say they're having the worst headache of their life, that is a huge red flag for a stroke, right? As you guys pointed out with your looking at hemorrhagic stroke, that can be a big red flag. When they say it's the worst, it's called the WHOL, worst headache of life. When that happens, that in itself is a red flag. Let's see. So what did you guys say about the assessment? Excuse me, let me close this door so that I can hear you better. What did you say about the initial nursing assessment with this patient?
You're going to take her vital signs and assess her pain on a pain scale.
Okay. Anything else? You're on mute, Mimi. Oh, Evelyn, you're on mute.
Check her pulses and her capillary refills.
Mm-hmm.
Her eyes. Get a list of her medications that she's taken. Has she been vomiting? Any nausea? Then we would do like comfort things, like just you know, dim the lights, because if she's having that big headache, and we would do that.
Okay, definitely you're going to look at her neurological status, right? Mm-hmm. You want to get that baseline, especially if it looks like she's heading towards a stroke, a hemorrhagic stroke of some description. You've got to get a baseline, a neuro baseline. Glasgow Coma Score.
Don't they do? Yeah, don't they do with the arms if they can hold up their arm?
Yeah, you can do. You can do what's called palmar drift. Yeah. But really, the first thing you're going to do is look at the pupils and check the pupil reaction. Mm-hmm. That's the first thing.
And you can tell a lot of times where they're talking, right?
Correct. There's, you're going to look for discrepancies with her face. You're going to look for speech, slurred speech, all of those types of things you're going to look for. There's I think one of you posted FAST, F-A-S-T, the anachronism. I think it stands for facial. I can't remember all of them, but basically slurred speech is one of them as well that you're going to look at regarding the potentials for a stroke. All right. So what's the deal with this lady? Vital signs look awful. Yeah. That blood pressure, she's heading for a stroke, as you guys stated. The headache and vision issues. It looks like they decided to do metoprolol IV. So you need to get an IV line in this lady, right? We'll practice that tomorrow a little bit, getting some access straight away. And, so we're going to check her blood pressure. We're going to give her the medication. Another thing is pain score, right? Looking at what her pain is so that you can then look at the difference. Oh, yep, you check for Perla. Thank you. Yep. So that's the other thing you want to do, because obviously what is a pain level right now and what is that like, so that you can then evaluate as we go on, is it getting worse or is it getting better? Are we helping or hindering, right? So those are some of the things that you want to look at. So a couple of things that came out of this, a BNP was done. What's a BNP?
Basic nutriatic so I don't know.
Peptides. Yep.
Yeah.
Yep. Well, I think we talked about that in our respiratory piece, right? It's looking at the receptors in the lungs and in the heart, and what it does, it's a measurement to see if basically there's some congestive heart failure there. That's what we're looking at. All right, so looks like she got given some hydralazine.
My question to you is, with this patient, when I worked in the hospital, there was always a stroke protocol. Things had to be done within half an hour so they can give that TPA. TPA. And they didn't give this patient TPA, and I don't understand why didn't they?
Well, the risk of TPA is bleeding.
Right.
So, the problem is that potentially she could actually have a big bleed. That's one of the big risk factors that is a balancing act. So that was the deciding factor. Yes, she has high blood pressure. Would we give TPA or not? Well, if you read on, it goes on to say that Miss Phillips is taken to the OR to evacuate a large subarachnoid hematoma from her brain. So the concern is giving TPA, which they probably evaluated from an MRI, that there was a hemorrhagic stroke there, or a hemorrhagic hematoma there. You could make that worse by giving TPA. That's the art of it, right? So if it was an infarct that was a clot and needed a clot buster, then you're going to give it. In this case, that wasn't the case. It's a hematoma. It's a swelling that she's got going on.
Okay.
So that's what TPA is, a clot buster. So that's the difference right there.
Okay.
Let's see. All right, so we talked about a little bit with her risk factors. She's overweight, right?
Yes.
Mm-hmm.
She weighs 200 and something pounds.
Yeah, her A1C level is too high too.
Yeah.
Yeah.
Did we skip questions?
No, we got it all.
Yeah, we kind of was answering questions at one time.
Okay.
And of course, we just talked about some of the, and as I say, she is young. Does it say, it doesn't actually say about the family history. I don't really see about any family history there, right?
No, and it doesn't really confirm if she knew she had diabetes or not.
Mm-hmm. But my point is that, depending on what's going on with her family history, because my point is she's a young lady to have all this going on. So maybe there's some genetics and family history that has occurred as well with her. Right. So let's see. Why don't the providers want that systolic going down too much?
That's what's causing, that was what caused the stroke.
We want to keep her brain perfused.
Oh well, yeah.
Right? We want to keep perfusion going on. Her brain, her kidneys. If we drop that pressure too much, it's not going to keep all that perfusion going on. Because right now, that's where her body is used to. It's used to perfusing at a higher level. So if we drop that pressure too much, then her organs are going to shut down. All right. So that's one of the issues there. So you have to sort of do it slowly, slowly, slowly. All right, so we noticed that the right side of her face and the right side of her arm is drooping and she cannot lift it. So she has had a stroke, right? And in this case, it's a hemorrhagic stroke. So well done. Team 1 or 2, I can't remember which way around you guys had it. The 3 of you, well done for recognizing a hemorrhagic stroke. And absolutely, she needed to go to the ER to have that hematoma removed. Okay. Let's see. And then, of course, getting back after all of this, once she stabilizes, I like the fact that you guys brought out what her needs are. It's a team approach. She's probably going to need rehab. She needs the case manager. She needs PT, OT, speech, all of those pieces to help her as well, right? And as I say, with her being young and having all of this go on, she's going to need a lot of education, isn't she, to prevent this from happening again.
Yeah.
And it could be some of the risk factors as well that we haven't really touched on is, and I've seen this happen, it's a case of, oh, I ran out of my meds and I couldn't afford them. Bam, they suddenly have a huge stroke, right? How many times have you seen that? Or they come into the hospital, I couldn't afford my meds. Now, you know, what blows my mind is with a lot of these meds, they're actually cheap as dirt, these meds.
Free.
And free. Thank you. You know, and so that's another massive educational piece for our patients, helping them to understand that these medications are free, and also helping them to understand where they can go to get a prescription for the free meds as well, you know, because there are free clinics, certainly in Jacksonville. There's some very good free clinics. So these are the types of things that we want to make sure that these patients understand so that they don't actually end up in these situations in the first place, right?
Mm-hmm.
Yeah. Yeah. All right. Well, good job, guys. Did you, and that's a good case study to do, I think.
Mike, can I just ask you a question?
Of course.
With her high glucose level, would they treat that too at the same time, or they worry about that after?
They would absolutely treat that too.
Okay.
Yeah, you wouldn't just treat something in a vacuum. You know, again, it could be, you know, a hemoglobin A1C is 9.2. Her glucose right now is 193. I mean, that's not too crazy. Obviously, we want it lower than that. Excuse me, but we're going to look at those things too. We're not just going to address one thing, because of course with diabetics, you know, everything is getting gunky on the inside, right? All of that sugar is clogging up her system, her brain, her peripheral. So that is a co-contributor, or predominantly the contributor to this hypertensive crisis. So we need to address that. So that's a great question. Absolutely, we got to bring that down. And again, we can use nice free meds for that. Metformin would be a great example. It could be that she's not been taking anything, you know. You know, understand what to take, and that's a completely free med, glyphosate or whatever she's going to need. Metformin would be a good one. But you know, a lot of patients can get the year supply of the patient assistance program. And so it's really just a case a lot of the time of plugging them in. A lot of patients don't realize that they can go to Walmart and get their
glucometer.
What do I want to say? Thank you. Not just the glucometers, but the whole shebang. really cheap. It doesn't have to be some of the expensive AccuCheck machines that you buy. These organizations, as I say, Walmart, do some really cheap options for people. So it really is part of our role, and I'm glad that you guys brought that out regarding utilizing the case manager, because this person really is going to need a lot of case management to prevent this occurring again, and obviously prevent a worsening of her situation, especially with her being so young. So good job, good job, good job. So why don't we do this? Why don't we have a 15-minute break? Let's meet back at 1:30, and I'm hoping I gave the link to Clifford Davis, and hopefully he'll be joining us at about 1:30, and you know, we can go over some dosage calc. Now, questions for you. Tomorrow, I was going to suggest that we meet between, say, 9:30 and 10 and go till 1. Okay, so it gives you a chance to get there. There's no rush in the morning to get there. I know some of you live, doesn't one of you live in Georgia or something?
Me.
Kaylin?
Me
Yeah.
too.
Oh,
I
you
do
live in,
too.
oh, you both do. I wasn't aware that. Where do you guys live? Like an hour away or
I live an hour,
further?
15 minutes away.
Mhm.
I live in Kingsland, right over the border.
Okay. Okay. So that's why I thought, because I actually have to be there till 6 o'clock that night anyway. So I figured if it's okay with you, we can start a little later. That gives you time to miss the traffic and it not be such of a rush. And we'll get started. I've booked the lab from the whole morning through 1. We'll probably be through by about 12:30, quarter to 1, but you know, that way I'll get you some little check-offs and things, and as I say, we'll just go over we'll have a fun time. All right. I did look to see if I could find a peak flow. There was an incentive spirometer, but I don't know if I could find a peak flow, so I'll see if I can have a rummage around and we'll see what we can find. Okay, so I just wanted to let you know about that tomorrow, but of course make sure you're in uniform and all of that good stuff. And you can come in the front entrance and they'll check your temperature. And then I thought 10 o'clock would be a good time for us all to meet. What do you think about that? Does that sound reasonable?
That's
That's
beautiful.
great.
You said 10
Yeah,
to 1? That is wonderful, darling.
That's perfect, Miss Fletcher.
Oh, good. That works out perfectly.
amen.
Yes.
Yes.
Good.
Great.
I figured that made sense, right? Miss the traffic.
Yeah.
Yeah. I mean, you're still there. You're going to do 3 hours of, you know, I think between the 5 of you, 3 hours will be enough. By that time, you'll be like, can we please stop doing this? Yeah.
Amen.
All right. Okay, perfect. And Mimi, as I say, the week of the 22nd that you're going to be out on that clinical day, that is week 9, right?
Yes, ma'am.
So that Tuesday, the clinical assignments for that week, if you want to start working on them beforehand, and you don't have to do it right now, I'm just giving you a heads up.
Yes, ma'am. Oh, I will.
And I'll make sure it's published and all that good stuff.
Yes,
All
ma'am.
right.
Thank you.
All right, I'll see you in about 15 minutes, and hopefully this will all go smoothly, and Clifford Davis will get the link, and you know, it's just going to go perfectly. I know it is. See you in a few minutes.
Yes, ma'am.
Bye.